Mission Hospital, MBBS from Medical College Kolkata, MD, DNP Cardiology, MNAMS and FSCAI. International and national publications, he had many to his credit, and he is speaker at many national, journal and state cardiology forums. Dr. Ganguly, please.
Good morning, everybody. Yeah, it's good afternoon. Well, I will speak nothing about cardiology. You know too much of cardiology for me to be spoken. What I would do is, I would love to talk about unspoken things in cardiology and vascular interventions. People forget that it is cardiovascular sciences where not only cardiology is there, but a hell lot of vascular things which we meet every day. For example, in your emergency, a ma'am and Dr. Shantanu were discussing about something pulmonological. But a patient comes to you having hemoptysis. What do? Any one of you. Person coming to you with hemoptysis. Sedate him, put some antiseptic, put some styptics, wait for the hemoptysis to stop. But it continues. People have having 250 ml, 500 ml of bleeding. You don't know what to do next. We are there for you. We can stop the bleeding by a small coil in the bronchial artery which bleeds. So there are certain things which are of interest to everybody. I would just love to scroll through them. I can stop anytime you want me to stop, because there is nothing which is written or to be spoken. Everything to be seen and to be discussed. A young guy walks into your OPD with a blood pressure of 220, 120, 18 years of age. What do? Put your hands in the pulse of the hand and the lower limbs. Hand pulses are bounding, lower limb pulses are not there. You diagnose it that the patient is a coaptation. After that, don't worry. This is the guy. You see the coact? This is the point where the coact is. We just take your balloon. You see the coact getting dilated. It is fully dilated. Then we take a stent. We are deploying the stent. You see the stent. And there is no more coact. The aorta has opened up. 6 months down the line, you had prescribed 8 antihypertensives that have come down to 3. In due course of time, it will come down to 2, 1. It will not be 0. But imagine, this guy, had he not opened up this coact, he would have come to your emergency with cerebral bleeds, with renal shutdowns, with heart failures. But just a little thing, you see him. This was what Dr. Bose was talking. Once in the surgical domain has come up to us. It requires nothing. 1 day admission. Just go in with a balloon and you see it gradually dilate. The mid portion was a valve which was so tight it has opened up. People ask me, why are you talking about balloon mitrals. See, we are not talking about balloon mitral valvotomies when the valve area is 1.5. You manage on medications. But when the valve area comes down to 1 or less than that, the patient will get some relief with Lasix, Lanoxin, and the drugs. But the left atrium will go on increasing in size. The patient will develop atrial fibrillation. Atrial fibrillation will lead to cerebral stroke. You open up the valve. The medication goes down. If you open it up at the right time before there is onset of a persistent pulmonary arterial hypertension, you may not require Digitalis and Lasix at all. So my plea will be, this is a very inexpensive procedure, costs you hardly 35,000–40,000 bucks. Imagine the cost of prescribing the drugs lifelong, the cost of morbidity, the cost of loss of man hours, add up together, it will be much more than the price of a balloon mitral. The only thing is, we don't know that it has to be done, and that gives a good result. If the patient is on a penicillin prophylaxis, for 15 years this valve will never come back and choke again. You have averted a mitral valve replacement, you have averted many other things. This was a gentleman who came from the collieries, ECL, a young guy, 25-year-old, had an accident in the coal mines, had a fracture in the pelvis. The orthopedician took him to the OT and he found that the pressures were not holding. He sent the patient to us. We did a digital subtraction angiography and you find the through and through dissection of the aorta. This is an aortic stent graft. We just, in the same setting, put in the stent graft. You see that the graft is opening up. The graft has opened up. We dilate the graft again with a balloon to appose it properly. Just a minute. And the dissection was sealed. After that, the patient had a pelvic surgery done and he went back to his job. Had we not done this, neither the pelvic repair would have been possible, nor the patient would have survived the next day. So it's an emergency life-saving procedure which can be done in a simple way, and the results are only but rewarding. I have selected only those patients whom we do not know that this can be done. A 12-year-old boy, he repeatedly presented with symptoms of easy fatigability, breathlessness, episodes of syncope and presyncope. There was an echo report showing a thickened pulmonary valve, but when he had a pulmonary valve with severe stenosis and a gradient of 110 millimeter mercury. This child, when we did an RV angio, this is the point of the valve. This is the balloon. You see two big dots. We are dilating the balloon. This tightest point was the valve. It opened up. This baby no longer requires a single medication. She's now three more years old than she was, appearing for the board examinations. She doesn't have fatigue, no breathlessness, no medications, and a normal life. This gentleman, 68 years male, came with limb claudication, diabetic, hypertensive gentleman. This is the low descending aorta, and you have the two common iliacs, which are tightly stenosed. You needed grafts for that, peripheral PABGs. Well, the surgeons are getting annoyed with us as time is going by. Only not because that we are robbing them of their food, but because we are becoming more friendly to you. No surgery is the thing that is our ultimate objective. Surgery is a majburi where you have to open up. So this we could achieve with two peripheral stent grafts. This is the stent graft, which will open up. You see it's opening up gradually opening up into the left common iliac artery, coming down to the common iliac artery, and you will have another stent in the right common iliac artery. This is another stent in the right common iliac artery to be put in. See, this is the other stent in the right common iliac artery. So now you have a pajama, and this pajama removes you of the thigh claudication and the symptoms. You avoided the surgery, you do it today, day after tomorrow, you walk home and you join your job immediately. Again, the question of man hours, the question of morbidity, the time for morbidity, the cost of morbidity, everything has to be accounted before you take into consideration the cost of the procedure. I go to the next.